Welcome, everyone, and thank you for joining today's webinar from the Positively Safe Project, Conversations with Infectious Disease Specialists, HIV Myths and Facts. At this time, I will turn it over to our wonderful hosts for today, Dr. Joshua Barocas and Dr. Julia Marcus, to tell you all a little bit more about themselves.
Thanks, Robin, and thanks for having us today. I think that I'm not speaking for Julia, but I know that I'm thrilled to be with you all. My name is Josh Barocas. I'm an infectious diseases physician at Boston Medical Center and Boston University School of Medicine. I treat people in the hospital and sometimes in the clinic who have different infectious diseases, including HIV, hepatitis C, and these days a lot of COVID. So that's all the introduction that I have for myself. I happily pass it over to Julia.
Hi, I am also very excited to be here. I'm an epidemiologist, infectious disease epidemiologist. I mainly work on HIV prevention, and that's what I've been doing for a long time. But I've also worked on some other infectious diseases, including hepatitis C and other sexually transmitted infections. I don't see patients. I work with data and try to understand ways that we can better implement what we know to work for HIV in the US. And yeah, that's probably all you need to know about me.
Great. And again, thank you both so much for being here. So I think we'll just dive into questions. And first things first, how is HIV transmitted?
So, Julia, I think I could probably answer the medical parts of these, but I think you're probably much better at answering most questions anyways than I am. But maybe from a population level, we can split it up those two ways, at least for this question. Is that okay with you?
Whatever, yeah, sounds good.
HIV is transmitted when with direct contact with certain body fluids. And so that includes blood, it includes semen or pre-seminal fluid. It includes rectal fluids, vaginal fluids, and breast milk. But in order for it for transmission to actually occur, a lot of things have to happen. But step one is that the virus from one person has to make it into the bloodstream of an HIV negative person. And this happens through those mucous membranes that we just sort of talked about, the rectum, the vagina, the mouth, or the penis, through open sores, cuts, or through direct injection. So it has that's sort of the first line that has to happen. If you don't have any of the virus going into your blood system, then there can't be transmission. There can't be established infection. Did I miss anything, Julia?
I don't think so. Okay. Wait, did you say through, what about through mother to child transmission?
I said breast milk. I said okay. Breast milk. Yeah, exactly. It's really rare. I think a couple things, especially since we're talking about facts and myths, it's incredibly rare, especially, and we can talk more about what decrease the risk of transmission, because there, like I said, there are a lot of factors, but just without any other intervention, it's really rare for this to happen via oral sex, via bites, blood transfusions.
Kissing, spitting on people.
Thank you. Yeah, none of those. Thank you. I was going for the other ones, but exactly, the ones that I mentioned initially are the ones that are the I guess, highest risk ways that the virus is transmitted.
So you could kind of distill it down to the main transmission routes are sexual intercourse and injection drug use. Is that fair?
Yes.
In the US in particular.
I think so. Yep.
Alrighty. So heading into our next question received from the audience, what precautions should I take when bringing someone in who has HIV to a shared living space?
Do you want to start with this one?
I am not sure any particular precautions need to be taken. Given what we just talked about in terms of transmission routes, there really isn't that I can think of, and you know, Josh may have additional thoughts here, but I can't think of any precautions that need to be taken in a shared living space, given that the main routes of transmission are through sex or you know, or injection drug use with shared needles. So I think I would say none, but Josh, what do you think?
No, I was thinking, so I'm not sure that precautions is the right word, but preventions, I guess, right? So it's not, so HIV is not like the flu or COVID, where we have to wear a mask just in being in close contact with each other, especially with COVID. But I think that in general, having a space that is that helps people understand their, I don't know that this is the right way of saying it, but that helps people understand their own risk is probably the only precaution that you would want to take, so that but no like medical intervention precautions are necessary.
Yeah, I think that's exactly right. Anything that you can do to ensure that the people in your living space understand how they can prevent their own risk of
Yeah.
HIV infection or transmission, that's a great precaution to take. Obviously, without calling anybody out, you know, if you know that they are living with HIV, but simply making sure that the people who live there have as much prevention information as they need.
Yeah. Yeah.
Right. If I could just interject as well, I think
Please.
you know, we have training resources and whatnot about having those conversations, because I think a lot of times advocates just don't know how to talk about HIV and the prevention pieces of that. So, you know, we're here to provide technical assistance to anyone, because it is important. Whether someone's living with HIV or not doesn't mean you don't have that conversation. Like, you know, we have to provide them at least some resources to say, you know, you experience domestic violence, that does, you know, open up more opportunity for transmission or acquiring HIV. So how can we help you? You know, whether that's getting testing or knowing the preventative methods that are available to them. So yeah, I think those are great points.
But I think to the point of actual precautions, right? Because, and I know that we'll be talking about this. I assume that we're talking about this in chunks of transmission and prevention and whatnot and treatment. From a precautionary standpoint, I mean, even if you shared a toothbrush, as Julia said, you can't get HIV from sharing saliva or giving someone a kiss. So if I share my toothbrush, it's not like we have to have a separate bathroom for someone with HIV versus not. That hit all the points of that one, Robin?
Yes, thank you. I'm actually handing it over to Ashley to ask the next question.
Great.
So, you know, in talking about this intersection, all the time, I frequently get asked, like, you know, I heard this story about someone being cured of HIV, and everyone wants to know, how far away are researchers from finding a cure or a vaccine? Any input you all have on that?
So researchers have been working for a long time on a cure and a vaccine for HIV and have not gotten there yet, but are still working on it. But there is good news in the sense, great news, that we have really amazing ways to treat HIV. So for people who are living with HIV, there's been just incredible advances in treatment to the point where people who are taking treatment for HIV have almost the same life expectancy as people who don't have HIV. So really can give you a basically normal life, and you can live a healthy, robust life. It's really they really are amazing medications. Those same medications can also be used for prevention, something called pre-exposure prophylaxis, kind of like birth control, but for HIV, where if you're somebody who's at risk of HIV, you can take a medication every day and prevent infection. And those are almost 100% effective. The other piece of good news is that people who are living with HIV who are taking medication and are successfully treated on that medication, they can't pass the virus on to somebody else. So it's like a foolproof way to prevent transmission. So even though we don't have a cure and we don't have a vaccine, we do have amazing ways to treat and prevent infection, and they're getting better all the time too. So we now have a new method of pre-exposure prophylaxis, or PrEP, that's going to be coming out soon. That's an injection every 2 months that works as well or even better than taking a daily pill. And that may look different a few years from now. Maybe we'll have something that can be an injection every year, or even longer acting. So then we're getting into the realm of prevention that looks a lot like a vaccine, even though it isn't actually a vaccine technically.
Yeah, and I'll just expand a little bit on the treatment and the cure part of it, because I think it's a really interesting story. I think both Julia and I have been. I say this because we're close friends outside of this Zoom call, anyways, and so we've talked about this. And HIV in general has been a fascinating topic for, I think, both of us for the last many years, and it's part of why we got into it. And the history of it. Is that a fair assumption? Okay, I didn't want to speak for you. So back in the just to go into how far treatment has come, when we talk about the treatments that people were taking back in the early 90s, these were at that point experimental treatments. And you can, even if you want to Google it, there are pictures of people that are holding, handfuls of pills that they're having to take on a daily basis, that at that point were had limited effect, really, but they were experimental. It wasn't until the mid 90s that we really started to, I don't want to say perfect, but really started to get what is now essentially combined antiretroviral therapy or treatments. And it dramatically improved people's lives and life expectancy. And at this point, even when I was going through my infectious disease fellowship not too long ago, I still had people, and we still have people on a number of different combination therapies, but at that point, a lot of my patients were still on more than one pill more than once a day. At this point, many of our patients are on, for treatment, one pill once a day. And most people that I talk to don't even bat an eye at it. In fact, many people's anti or high blood pressure medicine are more frequent than that, and cause more side effects. From a cure standpoint, there's been a lot in the press over the last 20 years about cure. To date, there have been two cures, but both achieved cure because and through bone marrow transplant, if I'm remembering correctly, through bone marrow transplants for malignancy. So they had some sort of leukemia or lymphoma, required a bone marrow transplant, and because it wiped out their entire cell lines of everything, which is what bone marrow transplants do, the HIV never was able to reestablish itself. So that's not really the way that we think about us. It's not really a sustainable way of getting to cure. It's not a recommended treatment at this point of bone marrow transplant. But as I think, as Julia said, individual cure following treatment, meaning we get rid of all of the virus, is not, we're not there yet. Hopefully in our lifetime, getting to a viral load that is below detection, meaning you don't feel it, you can't pass it along. That's sort of the standard care these days, which to me is, as having watched the story of HIV since the 80s, that is like the most remarkable thing that I think we could even hope for.
Great, thank you both for that. So moving a little more into prevention, we received a question. I know none of my program participants are having sexual relationships. Why is talking about prevention important?
So, so I would say, ideally, I would want every person to know about how to prevent HIV, regardless of whether they're currently having sexual relationships. So I would say that first of all, I think people need to have the information that they need to be empowered to make decisions about their sex lives. And they may have sex tomorrow, even if they're not having sex today. And also people don't always disclose what they're doing. So we have to, I think, assume that everybody needs to be armed with this information, regardless of what we know about their lives. And I think also, this is a challenge with HIV in general, is I think it's hard to tell right off the bat who might be at risk of HIV. It's not obvious. You can't look at somebody and just know this person, may be at risk of HIV. So ideally, we make sure that this information is really widespread. And also we want to remove the stigma that is associated with HIV and with talking about sex. And so the more that we can just make this information just kind of normalized and something that we talk about and share, I think that the better, and the more that we'll be able to prevent HIV, knowing that stigma really is a barrier to people coming into the doctor, talking about, their sex lives and accessing these prevention strategies. I think, being open about it, regardless of what you think people are doing, I think is really important.
Yeah, you stole my word, which is fine, of normalizing, right? Like, I think that's the word that I think about when I talk about HIV prevention with my patients. And I learned from a very early point in my medical career that the more the more I ask the question of my patients, to every single one, regardless of what I think my preconceived notion of risk might be in that person, it makes it easier for me to ask the question. So I made it a point early in my medical training for literally everyone, and I'm an adult doctor, so this is anyone from 18 to like 110. I just made it a point to say, are you sexually active? Are you with men, women, both? Do you use condoms? And at first I got funny looks from the like 110-year-olds. Then I got a lot of appreciative comments from the like 75, 80-year-olds, because I didn't make the assumption that they weren't having sex. And then it just became, but more importantly, it became easier for me as a clinician to ask the question, that it had nothing to do with what my preconceived notions were of the person that was sitting there. And so I think that the more we can normalize it for ourselves, even, the more we can help normalize it just in general. But I will say I got a lot of very funny looks from like the 90, 95-year-olds who were taken aback by the fact that I was asking about anal intercourse.
I think you both made some really good points, you know, around normalizing this conversation. I think, like you said, Dr. Barocas, the more you do it, the more it's just like second nature to the work that we do. But Dr. Marcus, you know, your point about like, we don't always know, right? We are not always being told if someone is in a new relationship, having sex, you know, even using drugs, all of those things that a victim may keep from us. You know, I think back to like the number of really good relationships I built with survivors. And then there were some that just, you know, there was a struggle to open up, and, you know, still finding a space to like be able to provide them this information, like knowing it was important that they at least had the knowledge, even if they didn't want to share with me that they were, you know, about to, you know, have sex with a new partner. So I think that's such a good point, is like, we don't always know. And we shouldn't expect survivors to always divulge that to us.
And I think we have to think about it as we would all like to believe that somebody feels comfortable telling us something, right? There's a little bit of satisfaction. We hope that we carry ourselves in a way that is warm and opening and whatever it is. But at the same time, people have had their own experiences, and for whatever reason, may not be ready to divulge anything or feel comfortable. And I think that effectively making it so that resources are available, conversations are sort of judgment free, and that even if the conversation itself doesn't open up the box and of divulging something, it doesn't mean that then, you know, having a resource available, having condoms available, having literature on harm reduction, those sorts of things available for people, because it's amazing. I always think about in our STD clinic, in our STI clinic, the bowl of condoms. Nobody's having sex, but somehow all of the condoms are gone at the end of the day, and that bowl of condoms needs to be refilled.
Yes, absolutely. Yeah, and I think that's a great point, for all DV programs to be providing condoms. I mean, it's such an easy thing to make available. So next question. If someone has, you know, they've let me know that they're living with HIV, they've entered our program, they said, you know, they're taking their medications. Is there anything else as an advocate that we could do for that person from your perspective?
So I can talk practically, aside from sort of just general support, but practically speaking, we want to make sure that all barriers to care are lowered as best as possible. So oftentimes people are coming into a program, it's a new situation, they don't know the bus route to get to the you know, those sorts of, how are they getting to their clinic if somebody or their appointments, and these days of course a lot of it is on telehealth. So do they have the resources to make sure that they can stay on their meds, that they can make it to their appointments, whether it's telehealth or in person, that they have transportation taken care of, that there aren't competing priorities for them accessing their care. And so I think that those are concrete. My brain goes initially to those concrete, okay, they're literally, we have to get them from point A to point B. How do we do that? What are the specific barriers for this person? That to me, especially if it's somebody who's coming in, who's a survivor, is maybe in a new program, There's a lot of unknowns. Many times those are the competing priorities. And so I think that we can advocate for people. Being an advocate for somebody that has HIV, that has disclosed their status to you, one of those concrete ways that you can help is making sure that their HIV treatment is continued.
Yeah, I'd agree with that. I mean, the only other thing I'd add is maybe asking them what they need, and there might be things that haven't occurred to us that might be useful for them. But I do think the access to healthcare piece is probably the most important.
Alrighty, so people are talking a lot about PrEP and PEP. We've mentioned it here. What is it? Do people still need to use a condom on it? What do advocates need to know about it?
Yeah, so we talked a little about PrEP before, which is the pre-exposure prophylaxis part. And then there's also, and all of these are using the same kinds of medications, the treatment, pre-exposure prophylaxis, and then there's post-exposure prophylaxis. And that's, making the analogy of PrEP to birth control, PEP is kind of like the morning after pill. So if you've had an exposure, PEP is something you can take in the next few days or start taking in the next few days for 28 days that can help prevent you from going on to have an HIV infection. So let's see, what do you need to know? So I guess I'll just sort of big picture these medications, Josh gave kind of the history on them, and now we're at a point where they're very safe, very effective, don't have a lot of side effects. And I'll stick with the birth control analogy. It's like taking a daily pill. You don't really think about it beyond that. For most people, they really are easy to tolerate. So and very effective in preventing HIV. At least I would say PrEP. I think we know a little bit less about PEP, but I think if you do have an exposure, it's certainly better to access PEP and try that than not. And then in terms of condom use, so I'll just kind of stick with the PrEP piece here. So PrEP is very, very effective in preventing HIV infection when it's taken consistently, but it doesn't prevent anything else. So it doesn't prevent other STIs, bacterial STIs like gonorrhea, chlamydia, doesn't prevent syphilis, and it's not going to prevent pregnancy, obviously. So although there are people working on ways to combine these strategies into the multi-purpose technologies that can prevent more than one of these at once. But right now we just have a pill that prevents HIV. So so not using condoms is okay in the sense of you're still going to be okay with the HIV prevention part, almost certainly, but you will potentially be at risk of other STIs and potentially a pregnancy as well.
Yeah, and I also think that it's important to define what exposure means, right? So if I am somebody who is walking down the street and somebody bites me, hopefully that never happens. I'm just coming up with like sort of but we don't know that person's HIV status, then it's very unlikely that you would need post-exposure prophylaxis. When we do post-exposure prophylaxis, the ways that we think about it are from a clinical setting, happens a lot in healthcare settings where a surgeon or somebody who's doing a procedure has a needle stick or a scalpel stick, which is common, and it's on a patient that has a known HIV status. So in those cases, those are sort of cut and dry. You had blood-to-blood exposure with somebody that was known to be HIV positive. We put that person on post-exposure prophylaxis. With PrEP, again, I think to Julia's point, it really, STIs aside, right? If if you're having unprotected sex, either vaginal or anal intercourse, with somebody who is on their daily regimen of antiretrovirals, remember, they're one of the factors in transmission is how big their viral load is, how much virus is floating around in their blood. And so if they're not on treatment, then their viral load is higher, in which case the likelihood of transmission is also higher. If you're in a relationship with somebody who has HIV, or you've had exposure, you've had a sexual encounter with somebody who is HIV positive on treatment and their viral load is very low, then both PrEP and PEP, we have to make those sort of those are clinical decisions that I would encourage people to talk with their provider about, because the risk ends up being low as it is. This is what you might have heard in the news of as treatment as prevention. So if somebody who is infected has a low viral load, it's very unlikely that they're going to transmit the virus. I don't know if that made sense. There's a lot of words that just came out of my mouth.
So another way that people talk about it is that if somebody's viral load is undetectable, then they are untransmittable. So you might hear people say U equals U. That's kind of the catchphrase for it. And it's really just amazing news for HIV that's come out in the last few years that you know, people who are successfully treated don't pass it on.
Yeah.
So we got a question from an attendee. They're asking if getting clients or survivors to start using PrEP, or more people in general, I think, to start using PrEP, would this eventually maybe change the views or change the ways that we view those that are living with HIV? Do you think this could be a game changer for like the stigma around HIV?
Yeah, I mean, I think it already has. PrEP has been around for almost a decade now. It was approved by the FDA in 2012. And I think, you know, at that time, there was a lot of hesitation around it, a lot of concerns about how it might change people's behavior and how, you know, whether it was going to replace condoms, and concerns that people would, you know, go crazy and there'd be sexual anarchy. But I think now those concerns have really settled down and people are embracing PrEP more. That said, there's still a lot of stigma around it, but I do think PrEP has allowed for an overall reduction in stigma around HIV. And one of the reasons that's happened, not just, I mean, there's the sort of normalization of PrEP in society, like the more that people are aware of this, the more that stigma gets reduced. Also, the more that people are aware about U equals U, that also helps reduce stigma, because people living with HIV are you know, there's less of this perception that people are infectious, right? But also PrEP and treatment as prevention both have kind of facilitated, I think, more relationships between people who have different HIV status. So there used to be, I think, a bit more separation in the community between people living with HIV and people who were HIV negative, and PrEP and U equals U together kind of make those separations a bit less distinct, if that makes sense.
Yeah, I agree.
So we had another question that came in previously. Is it important that I let other program participants know that someone they're living with has HIV? Also, what do I do if I find out they are in a sexually active relationship?
So I think just going back to some of the earlier discussion, is it important that you let everybody else know? No. You know, I don't know that I have much more to add in terms of that. I do want to make I know that there's a second part of this this question. But what we're trying to with all of this is in this whole normalizing process, and getting rid of stigma. Part of it is my, I'm going to say my fault, the medical profession's fault uh, for what's called HIV exceptionalism. That there's been for a long time. This is the way that we handled HIV, both at the government level and at the medical level, has made it, we've perpetuated, and by we, I'm literally pointing at myself. No, I'm not talking about anybody else on the screen, but we've made it this exceptional disease that's different than everything else, and that has added to some of the stigma. And so I'm while I answered the initial question is no, you don't have to, let you shouldn't tell anybody else. It's not, it's not necessary. um, I think my hope is that we can move away from, we're moving out of a time where like that actually even is a, and I'm not saying it's a bad question, but I'm hoping that we're moving out of this era, this post exceptionalism era, where HIV is just the same um, as acne or any other medical condition where we have medical problems, we have diseases, we get cancer, and it's nothing that necessarily needs to be hidden, or that people who are infected feel like they need to hide. But of course, just like any other disease, it's our body, and we don't, and there's no reason to necessarily have to share it with anybody else. I know that there was a second part of that question. I forgot it, mostly because I went down the exceptionalism.
Sure. The second part was also, what do I do if I find out they are in a sexually active relationship?
I think that again goes back to what we were talking about earlier around making sure that people have the prevention information and tools that they need and that they have access to healthcare. So there's nothing that you need to do to keep that person from having a sexual relationship or any concerns. There's no concerns about it. It's more about making sure that they have what they need.
I think that we probably both classify ourselves as harm reductionists or risk reductionists, and so we want to make sure that part of the job, if you know somebody's HIV positive in a sexual relationship, in sort of a judgment-free way, we want to make sure that they have everything that they need for themselves to be healthy and safe, and however that's defined by them, and also that that whoever their partner is, that there are resources and that there are ways that we can help them reduce risk of transmission, whether it's through PrEP or condoms or whatever it is. We're both on the harm reduction side of things, keeping people in, as opposed to forcing them out and forcing them to feel more ostracized than maybe they already do.
Right. I think that's a great point. Is part of our jobs as advocates is building trust with the survivors, and being able to help them, in whatever ways they need. So, by outing them or ostracizing them, we've ultimately destroyed that relationship that we've built. I think the other important piece of this question comes down to confidentiality. The Violence Against Women Act, the Family Violence Prevention and Services Act, and the Victims of Crime Act have very strict confidentiality measures in them that protect survivor information. So if a survivor discloses to you that they are living with HIV, you have to hold that in confidence. Unless they have signed that, that waiver that allows you to, provide that information to who they've noted. It is your responsibility as an advocate to make sure you keep whatever confidential, and that includes confidential from other people in your program.
So another question crowdsourced. No one in my program has HIV. No one who's come in has even mentioned it. Why should I be thinking about this? Why should we be talking about this?
At the risk of repeating ourselves, I think I'll just say, like, so one of the things that I work on in my research is trying to get doctors to talk more about PrEP with the patients who are most likely to benefit. And one of the barriers is that doctors say, I don't think any of my patients are at risk. I don't think any of my patients have this. I don't even think they're having sex. Like, they just don't, it's not on their radar. And understandably, there are, like, 50 other things they have to deal with at a primary care visit. They have 15 minutes. But part of the problem there, I think, is this assumption that nobody really needs this information. This is not a problem. And admittedly, HIV is rare, thankfully, in the US. And so it does fall off the radar screen. But I think, as evidenced by the tens of thousands of infections we still see every year, there really is a need to get this information and these tools out there widely. And so I think we can't wait until there's a problem to give that information. The whole idea with prevention is to make sure the information and the tools are there when people need them. And we can't always anticipate who's going to need them and when they're going to need them. And so they have to just be there. So I think, there's the normalization piece, and there's also just kind of the pragmatic approach of making sure that people have what they need when they need it.
Yeah. And, this just triggered my memory that we've talked a lot about sex in the last 45 minutes and not a ton about drug use. And I noticed a chat comment earlier that it's not drug use. And I want to make sure that everyone knows drug use itself is not a risk factor for HIV or for bloodborne infections. And I think that that was a really good point that was brought up. It is, there's nothing inherent about heroin that gives you HIV or methamphetamine that gives you HIV. It's the needle and drug injection, the equipment or drug preparation equipment those are the sources. So when people are sharing needles, cookers, cottons, water, and syringes, that's how your risk is increased. So that was I think a really important point. The other is that to Julia's point about how well we assess risk, we assess sexual risk factors in medicine and just in general pretty poorly, I think. But we assess drug risk factors even worse. And so I think that that's not the fault of anyone who asked the question. I do it constantly in my assumptions of seeing patients that this person doesn't look like a drug user. And my life revolves around drug use, and I'm still really bad at assessing risk for drug use and risk. And then even more so, I'm even worse at assessing risk for the practices that put you at risk for HIV with your drug use. And then there's the intersectionality. And I know that we're talking about a lot of survivors, and we're talking about survivors in this particular setting, but there's an intersectionality between drug use and sex. oftentimes forced sex. And so I think that's just one more layer as we're talking about all of this, that all of this is much more prevalent than I think many of us, even those of us that spend our days thinking about sex and drugs, and HIV, really account for.
Alrighty, so that actually segues perfectly into our last question. It's dangerous for me to let someone in my program with HIV because they're probably doing drugs or selling sex. I want to keep everyone safe.
Yeah. So there's a lot. I'll hit on the drug use part of this first. There's a lot of stigma around substance use in general. Substance use is, and generally speaking, talking about opioids, stimulants, benzos, a lot of different drugs at this point. By and large, we have to think of it as a chronic disease. Not even by and large, it is a chronic disease. Substance use disorders are chronic diseases. And substance use alone doesn't make one a dangerous person, doesn't make them bad. It's not a moral failing. People fall into drug use for a number of reasons. Sometimes it's forced, and we see a lot of intimate partner violence through drug use. And because of the way that opioids specifically work in the brain, their addiction often develops, and so oftentimes it really has these are people who have not made a choice to become addicted to a substance. It is a disease, and so I think that as we talk about drug use, we have to look at people first through the lens of that chronic disease, and second, that with any chronic disease, whether it's drug use, HIV, diabetes, high blood pressure, anxiety, whatever it happens to be, the best thing that we can do is provide a supportive environment, a safe, supportive environment. Have many make sure that many of the things that are structural barriers to treating that disease are addressed or taken down, and then eventually trying to find treatment when people are ready for their substance use, or for their diabetes or whatever it is, right? And so I would very much encourage people to think about drug use as diabetes. We wouldn't not accept somebody into the program because of their risk of eating cupcakes, and their risk of needing insulin, and their risk of hyperglycemia. Similarly, I think that drug use should be looked at similarly. I don't know, Julia, did I?
Yeah, so the other part of the question was about selling sex, I think. And so I would just echo what Josh was saying about drug use, that people who are selling sex are not inherently dangerous, that sex work is work, and that many of the dangers that are associated with sex work are to sex workers themselves and are really more about sex work being criminalized and stigmatized. And so I think I wouldn't hesitate to welcome a sex worker into your program, and rather I would really be thinking about how can I support this person and ensure that they have what they need so that their sex work can either be safer or so that they have the option not to engage in sex work if they choose.
Yeah, and I think you hit on something really important that I'm glad that the word that I didn't bring up was, it's a lot of this has to do with the criminalization of sex work, the criminalization drug use, and the criminalization of homelessness, right? Like many of these things that are very much associated with that have a lot of stigma attached to them have to do with the fact that that they've been criminalized, and so as a result, we think of them as bad. And in general, that's not the case.
All righty. Well, thank you both so much. Ashley, is there anything else you'd want to say before we wrap everything up?
Now, I just had a question because, you mentioned COVID recently, and I was just curious. I have a couple of friends that are living with HIV, and they just got their COVID vaccines. But are there any studies that have been done around the COVID vaccine and maybe interactions with ARTs, or what is known about kind of this intersection?
So that's a fantastic question. The large vaccine studies at this point, of which there are now 3 that are publicly available, and we're just looking at randomized trials, are the Moderna, the Pfizer, and the Johnson and Johnson vaccines. I don't recall there being a specific, Julia, tell me if I'm wrong. I don't recall there being a specific line item for HIV, but as far as I know, based on the recommendations of HIV-MA, which is the HIV Medical Association, and the Infectious Disease Society of America, and the International AIDS Society, there's no concern currently for vaccines and ART.
Or for vaccines and HIV infections.
And for vaccines and HIV. And in fact, I think I'm trying to hold in as much of my excitement about the COVID vaccines, because we're not talking about COVID vaccines here today, but they are, since we can, and that we can give a plug, they are incredibly effective, incredibly safe, and I would encourage everyone that when you have your opportunity to get whichever one is offered to you.
Great. Well, thank you so much, Dr. Barocas and Dr. Marcus. It was really such a pleasure to have you both today.
Oh,
Thanks for having us.
Yeah, we appreciate it.
I also want to thank all of our attendees today for your ongoing work with survivors, especially during these challenging times. We will be sending out a recording of today's amazing webinar in the next few days. I also just dropped an evaluation in the chat. The Positively Safe team is also excited to announce we will be hosting a 3-part webinar series beginning on March 10th, titled The Introduction to the Intersection of Domestic Violence and HIV. We will share those links to register for the upcoming webinars in the follow-up email. So this concludes today's webinar. Thank you all for attending, and have a great rest of your day.
Thanks.